Hey guys, and welcome back to MS NEURO TV, brought to you by MS Views and News and sponsored by Sanofi-Genzyme, Biogen, and Celgene. It's so great to have so many of you back with us again. This is Ana Fernandez de Castro, the Assistant Development Coordinator at MS Views and News, and I'm also here with our Director of Development, Jennifer Falk.
Hi, everyone.
All right, so first, we'd like to give a big thank you to all of you who are joining us here tonight. We're so glad that so many of you have been enjoying our webinars every month, and we are reading all of your comments and your feedback. So thank you to all of you for the kind words, suggestions, and for your support, which helps to make this series possible. So if this is your first time joining an MS NEURO TV webinar, then welcome. We hope that you enjoy our monthly series of interviews with multiple sclerosis specialists. MS Views and News is a nonprofit organization dedicated to providing education and information to the multiple sclerosis community. Okay, so today our special guest is Dr. Donald Negroski, and he'll be speaking with us about how to know when to switch your MS therapy. He'll explain when you want to consider making this big switch and how to discuss this with your neurologist and with your MS care team. Dr. Negroski has been a neurologist for 32 years and is the medical director of the Multiple Sclerosis Center of Sarasota in Florida. He is also a clinical assistant professor in the Department of Clinical Science at Florida State University's College of Medicine. Dr. Negroski has made numerous contributions to clinical trials and has been an expert presenter nationally and internationally in the field of multiple sclerosis. His achievements have earned him multiple awards and is listed yearly in the Guide to America's Top Physicians. Okay, so tonight we'll begin by playing a short video interview with Dr. Negroski. After the video, Dr. Negroski will be available for a live 20-minute Q&A. We know that your privacy is important, so we will keep your questions anonymous. We just ask that you please keep your questions on topic, and please don't forget to complete the quick survey that's going to pop up at the end of the webinar. So, for those of you who are calling in over the phone tonight and do not have video access, please know that you will hear a few minutes of silence while we play a pre-recorded video interview. But please don't worry, stay on the phone because once the video is done playing, you'll be able to hear us again during our live Q&A with Dr. Negroski himself. Okay, let's begin.
Welcome to MS NEURO TV, presented by MS Views and News. MS NEURO TV is a comprehensive educational program bringing together MS professionals from across the United States covering the topics that you want to learn more about. To register for MS NEURO TV webinars, visit www.msviewsandnews.org. Thank you. We hope you enjoy the program.
So, Dr. Negroski, how do you know when a patient needs to change medications? How do you know when it's time to switch? Is it something that you come up with, or is it something that the patient might feel and bring to you as well, based on maybe some progression going on with their disease? How do you actually put it all together and say, hey, it's time to switch and try something different?
So the question is, when do you change your therapy First of all, we all know that MS therapies are effective. They're not 100% effective, but they are effective. Since they're not 100% effective, there's no one right drug for every patient. So some patients don't respond to the drug that we decide to put the patient on. So when do you kind of pull the plug and move on to the next drug? So that dynamic has shifted in the decades I've been treating MS patients. So before, when we only had a small group of drugs, we tended not to shift because there was only two classes, the interferons and gluteromer. There were 3 interferons and 1 gluteromer, and if a patient failed an interferon, sometimes we wouldn't do the same class. We would go on to a different class. So now that there's 17 FDA-approved drugs for MS, our options has blossomed. And as a result, our kind of threshold to pull the plug on a drug has lessened. So why is that important? Because in MS patients, I ask my MS patients, what's important? Is it for relapsing MS? Is it relapses? Is it disability progression? Or is it MRI activity? All 3 are important. But if you have breakthrough of disease in any one of those, that could be grounds to change therapy. Because if you don't change therapy and stay on the same treatment, there's a potential that the patient could have more relapses, could have increased disability progression, and MRI activity. So the next question is, how do we monitor that with patients? So obviously with relapses, it's important to ask patients and their care partners if they've experienced a relapse. So what's the definition of a relapse? In general, a definition of a relapse is something new that you haven't had, or intensification of a pre-existing symptom that lasts at least 24 hours. Some people say it has to last about 48 hours, but 24 hours. And you should not have a infection or a cold, or you shouldn't have a fever, because that can cause a pseudo or false relapse. So that's kind of the definition of a relapse. So patients kind of know that. The other thing that we look for is MRI activity. And surprisingly, you can have many more MRI lesions in your brain before you have a symptom. So the MRI could be a surrogate marker for disease activity before you actually get a relapse. So if you follow patients with yearly MRIs and you see more activity, then you sit down with the patient and the care partner and see if things should change. And then the last thing is disease progression in terms of disability progression. And that can come on very slowly over time. So what I tend to tell patients is, like, when you go to the store, the grocery store, and push the cart around, do you gather all the groceries at one time, right, like you did a year ago, and now you're not gathering the grocery, you're taking two trips. So that may be kind of an idea of how MS can kind of worsen your disability over time, and that's important for me to know so I can have that conversation with the patient.
Dr. Negroski, thank you very much for doing this interview series with us for 2018.
Okay, that was terrific. So this is Jennifer Falk here, Director of Development over at MS Views and News. And now it is your time. Everybody out there in the audience, we've got a lot of people joining us tonight. This is a really important topic, and I really encourage you to ask your questions, to type them in. Nobody can see who is typing. I will read them in the order that they come in, and we'll try to get to as many questions as possible. And remember that your question may not only apply to you, but may help someone else that's listening tonight. So we really encourage you to to ask questions if something comes to mind or something hasn't been answered for you, to start typing. You'll see a box at the top. You should see a box at the top right-hand side of your screen. And if you don't see that, look for an orange arrow. Click that arrow, and it should make the question box available to you. So it will say type questions here in the question box. So without further ado, I'd like to welcome Dr. Negroski on the line. Dr. Negroski, welcome. Thank you for joining us this evening.
Oh, thank you for the kind invitation, Jennifer. And I want to thank everyone for joining in. I think this is a very important topic for patients, and not only patients, their care partners that should be actively involved in kind of decisions about drugs and changing drugs and escalating drugs. So I'm here to answer questions.
Thank you, absolutely, and we're so glad that you're here with us tonight. I have our first question that's come in. It says, I am currently on Plegridy and considering Ocrevus. Is there any pre-planning required to go from Plegridy to Ocrevus?
So the question is, do you kind of rank drugs in terms of side effect profiles and methods of administration and risk of potential side effects and benefit of drug? Or if the drug that you're on, is it currently doing the job it should, and then why would you want to change? So that question has a lot of nuances. So, we should discuss switching medication in patients with relapsing MS. The recommendations is that we must change is not the proper term. We should make discussions about switching. So when you switch something, if a patient with relapsing MS has more than one relapse or maybe two or more MRI lesions and increasing disability, assuming that they've been on the drug for at least 6 months, some people say at least a year, then you should have that conversation to switch. Then you look at the mechanism of action of the drug, and some of the newer drugs have what's called legacy effects in terms of long potential changes in your immune system, the way your immune system works. So some of the newer drugs can change your immune system for quite a long time, perhaps several months, perhaps several years after you've received the treatments. And then you have to think about, well, if you can't tolerate those drugs, how do you go back to the other drug when you know your immune system has been affected already from the decision you made? So that's where it's important for the neurologist to kind of get involved and lead the conversation about which drug to change to, why you want to change. Are you having side effects of your current drug? Are you having, is it not working for you? So there's a lot of little nuances in that excellent question.
Yes, there is a lot. And you brought up something about the immune system. And I wanted to ask about long-term safety of sequencing, and exactly if you could explain to our audience what is sequencing and how the immune system needs to be taken into consideration when making a decision on what disease-modifying therapy to choose.
Well, the general thought is that the long-term safety of sequencing is still relatively unknown, because a lot of these drugs, even though they've been in the clinical trial, there's not a lot of real-world experience in terms of following potential complications of drugs. That's number one. Number two is the drugs that are currently available have been studied in certain age groups, typically between 18 and 55 in general. So what happens if you are 60 or 65 or 70 and you've been on a drug that will change your immune system? We don't know, because as you age, the immune system ages along with you. So the potential side effects may not be known, and the benefit of the new medication may not be known as you are on the drug for several years with advancing age. So no one knows the answer to that question, and that's why it's important to have shared decision-making, educate patients, educate their care partners about the nuances of any kind of decisions before you kind of just jump from one drug to another.
Okay, well, that kind of leads into our next question. I have someone asking, what if my doctor does not want me to switch, but I want to?
Years ago, physicians were trained to be paternalistic in their approach, which meant that we told the patient what we think that the patient should be on. And we all know that that's not the proper approach, because what happens is that the compliance goes down. The patient is not satisfied with the drug that was chosen for him or her. So now there's this concept of shared decision making, and when I talk to patients and their care partners, I try to get inside their head, so to speak, to see where they're coming from. See if they are risk adverse, if they want a drug that has minimal side effects, or if they're comfortable with a drug that may be more efficacious but may have potential serious but rare complications. And then you talk about methods of administration, and I tend to narrow it down to maybe 2 drugs. Personally, if a patient is really adamant about going on drug X, and I think they should be on drug Y, I'll put them on drug X, but kind of have an understanding that we'll try it for maybe 6 months and see how they're tolerating it, see if it's doing the job. But if it's not doing the job, they should be open to maybe choosing a drug that I think that might work a little bit better. So it's not a black and white thing. At least the way I practice, I tend not to be paternalistic anymore, and we come up with a shared decision that is right for the patient and they're comfortable with, and I'm comfortable with as well.
That's great. Thank you. And switching gears to a little bit more detailed question. I have here, just a second, I just lost it. In regards to Ocrevus, this person is saying, I understand it is an infusion and it takes about 6 hours. I have heard that the first infusion takes more than 1 session. Is this true?
So the way Ocrevus is administered, the first dose, it's a 600 milligram dose. But the first dose is separated into 300 milligrams, and then 2 weeks later, another 300 milligrams. The infusion duration is a little bit longer initially, and for each infusion, and then every 6 months thereafter, there's only 1 infusion, but it's the 600 milligram dose. As with any kind of infusions, the infusion rate can be adjusted up or down, typically not down, but we can adjust it a little bit longer if a patient has trouble with side effects during the infusion in terms of chills, or maybe they get a headache or some nausea and stuff. So the infusion specialist can kind of adjust it on the fly, so to speak.
Okay.
So it kind of depends on how the patient is tolerating the infusion at the time.
Okay, great. All right, thank you. And I have another question. Someone's asking in regards to switching to any drug for secondary progressive MS. Are there new drugs? Are there any drugs in development? And what is the status?
So the drugs, majority of the drugs to date are for relapsing MS. People with relapsing MS know that the longer you have relapsing MS, there is an increased risk of going into what's called the secondary progressive phase. Unfortunately, we do not have a lot of drugs that are FDA approved for secondary progressive phase, but they are looking at some in the pipeline. There's been some secondary progressive trials in Europe, and similar trials were carried out in the United States, and the results were kind of different between the secondary progressive patients in Europe versus secondary progressive patients in the United States. So there's a little mismatch, and some of that has to do with the age of the patients that were enrolled in the trials overseas versus here, their duration of MS and things like that. So it's the current drugs are for relapsing forms of MS, majority of the current drugs, but we have some in the pipeline being studied.
Okay. And I have another question asking, how many relapses and over how long of a period of time do you feel justifies a change of your disease-modifying therapy?
So in general, if a patient has one or more relapses and they've been on the drug for a year, I should have a conversation about switching or changing. It doesn't say you must. There's a difference between should and must. So we have a conversation, go over the pros and cons, and a lot of it will depend on the location in your brain or spinal cord of the relapse. So you can have a kind of a sensory relapse where you can have some numbness, but it really doesn't produce that much disability. Or you can have a severe relapse in your spinal cord and you can have significant weakness in your legs and ability to get around and do things. So if a patient has kind of relapses in eloquent areas of the brain that leads to, in my opinion, increased disability, my threshold of changing would be different than those patients with kind of a very, very mild sensory relapse. So not all relapses are the same. Having said that, just because you have a relapse, that means that your MS is active. It's still causing some problems. So the next relapse you have, you may be more severe. So that's why you should have the conversation to go over the pros and cons regarding switching.
Okay, great. And you mentioned in the video to have yearly MRIs to monitor progression. What is your opinion on yearly MRIs using contrast now, knowing new findings that there is warning or suggestion against using contrast?
So it kind of depends where you are in the diagnosis. Early on, I personally like contrast. The contrast agents are basically divided into two major classes. The original stuff that is in the press about the contrast being deposited in certain parts of the brain is with some of the agents that we tend not to use anymore. Does that mean it won't happen to the newer ones? The answer is we don't know. Does it mean it's going to cause problems? If it is deposited in your brain, the answer is that we don't know for sure. So there's a lot of unknowns. If a patient has strong feelings about doing a contrasted study just on routine yearly follow-ups, then I don't do it. I just do a regular MRI without contrast. And I think an MRI without contrast is a lot better than no MRIs to follow patients with MS. So I'm fine with that.
That's great. That's great to know. Thank you. And I hear this question a lot. Taking my disease-modifying therapy, but I still have many symptoms. I still don't feel well. So would that be a reason to change my disease-modifying therapy? So it's, asking, does my disease-modifying therapy really address symptom management?
So that comes up a lot. I mean, all the disease-modifying therapies are there to kind of decrease progression of the MS activity. They're not there to get rid of your symptoms. So we want to use therapies to prevent permanent brain damage or permanent lesions. If you have a permanent lesion, you may have permanent symptoms. That's unfortunate, but that's what we're trying to prevent from happening. So in general, the disease-modifying therapies do not improve your symptoms. That's why we have symptomatic therapies, besides disease-modifying therapies. Therapies for stiffness or spasticity, bowel and bladder dysfunction, pain, things along those lines.
Okay. And I do have a specific question. Someone is writing that they're on Tecfidera for 4 years, and their white blood cell count is dropping, and they're considering stopping at 67 years old altogether. They have relapsing remitting MS. Do you recommend stopping, or do you recommend continuing on a different or changing?
So in general, Tecfidera, a small percentage of patients can develop low lymphocyte counts, which is the subset of the white blood cell count. So with Tecfidera, the concern is that some patients with a very low lymphocyte count that is persistently low for greater than 6 months may be at a higher risk for a rare but terrible side effect called PML. So that's why we monitor patients, and personally, if some of my patients develop a very low lymphocyte count that is persistent, I have the conversation to take them off of the drug and switch them to something else that may not have the same side effect.
All right. Well, thank you, Dr. Negroski. This has been a lot of information and very, very informative and helpful. We're very grateful for you sharing your expertise and experience with us. Thank you very much for joining us tonight.
Okay. Thank you, Jennifer. Thank everyone else on the line as well.
All right. Will do. Thank you. And bye-bye. I believe that Anna still has some information she'd like to share with all of us about the next webinar. Anna?
Yeah, great. Thank you so much, Jennifer. And thank you, Dr. Negroski. That was really great. So thank you for that. And thank you to all of you who have joined us today on MS Neuro TV. I'm sure that many of you will also be very interested in next month's topic. Next month, Dr. Megan Weigel will be back with us to talk about staying active with multiple sclerosis. She'll be going over topics such as the impacts of movement, physical therapy, and yoga on multiple sclerosis. This next webinar will be on Tuesday, October 9th at 8 o'clock p.m. Eastern Daylight Time. So those of you who are joining us live are already registered for the entire series. Just keep a lookout for our reminder emails for further instructions on how to join our next webinar on October 9th. If you're joining us on YouTube and are not registered for the series yet, you can find the registration link on our website or in this video's YouTube description. All webinars are uploaded on our MS Fusion News YouTube Learning channel within the week. So make sure you subscribe to our channel and turn on your notifications so that you can get alerts on our latest uploads, including videos of our live events. You can also follow us on Facebook, Instagram, and Twitter. And if you're enjoying these webinars so far, please visit our website and check out our free live educational events that we hold all throughout the United States. If you don't see your location, don't worry about it. Locations are constantly being added, so just keep a lookout for this. For more information on any of our events and what's new in the world of multiple sclerosis, please visit us at www.msvn.org. And last but not least, we'd like to say a big thank you to Sanofi-Genzyme, Biogen, Celgene, and viewers like you for your ongoing support to make this program possible. Thanks to everyone that's joined us today. Please make sure you fill out the quick survey that's going to pop up at the end of this webinar, and we'll see you all again next month.